Hello, thank you, Chairman, panelists. So corneal rings complications can be divided into two, intraoperative and postoperative. So intraoperatively, we have bridges, perforations or intrusion, and false tunnel. False tunnel can happen anytime, but typically in post-LASIK cases, like in this case, as you can see with the OCT, there was a false tunnel where the surgeon went into the shallower flap in the face instead of going into the deeper target tunnel. But that can happen even in regular keratoconus. If a false tunnel is created, it's going to be like a vicious cycle where the surgeon will have a tendency to go again into that tunnel. Postoperative complications, by far the most common postoperative complication is actually anterior stromal necrosis, as you can see here. Now, this is a flagrant example. However, this can present much more subtle. And in this case, you might think this is just an epithelial defect overlying the ring segments. Only if you do an OCT, only to discover that there is a cleft all the way to the roof of that segment or the roof of the tunnel. Now, things can be a bit more subtle, like in this case, where you have just stromal thinning overlying a hexagonal intact due to the compression of the pressure. Another example here, where we have stromal infiltrate, they're sterile, with a stromal liquefaction on top of it. Now, let's take it a notch, a little bit more. And then, as you can see here, we have the same corneal thickness, but what you see is epithelial thickening. Now, we've listened to the talk before by Carolina, and that the four rules of the epithelium should be thin over a corneal ring segment at the very top and thick right after. So if you see thickening over and overlying corneal rings, then definitely there is stromal liquefaction and stromal thinning in there. What's the percentage of anterior stromal necrosis? 7% if you're using a microkeratome published by the late J.C. Awwad. We thought we're gonna get better if we use femtosecond laser, and we published it in JRS, it's only 5%, so not much difference. So it can happen in otherwise perfect surgery. Now, if you wanna remove a corneal ring segment with anterior stromal melt, I advise you not to go into the incision. You might think you're gonna find the tunnel, it's gonna be very hard, trust me. So what I use is use a diamond knife right next to that segment and try to engage it with a Mickey. Now, at this level, I'm exactly at the same level. What I want to do is go below it, so deeper to it. So what I go ahead and go for a deeper setting, go deeper to it, and I don't have to be right into the tunnel. That's the nice thing about it. I just have to be maybe a couple of dozen microns, and then with the Sinski, I can sacrifice all those stromal fibers that are sandwiched between my Mickey instrument and my segment, and just engage it and take it out, like you can see. This works, like a charm every single time. Now, as you can see here, the stromal melt is bigger. You might think it's small, but once you remove the ring, everything collapses. That's another example where actually I removed that segment and inserted in that same tunnel a CAIRS, corneal allogenic ring segments. I use my technique, the jerk technique, to make it stiff. I put sutures to close the defect, but at the same time to secure the segment and avoid it to go through that opening. Now, this is an example of a patient where we removed the corneal ring segments and did nothing, and you see this epithelial ingrowth all the way down to the floor of the channel. The other eye, where we actually explanted it and exchanged with a CAIRS instead. Look at the topography. That's the first eye. You can see regression in the corneal topography. Look at the other eye, you see a preservation, and actually even better. The topography postoperatively is better than preoperatively. We have published that in GRS in a case series comparative between explantation and exchange. Now, the second complication postoperatively in the anterior chamber intrusion. This typically happens in triangular corneal rings, but also happens in very deep rings, any type. This is the patient where actually before the ring removal and after ring removal, you have to remove that ring, and not much of a change because it's very deep. Now, look what happens 2 months later, you still have some edema and the tunnel is still wide open. So in that case, we could not go back and put a PMMA ring. What I did is actually putting a CAIRS exactly at the same position, however, 250 micron shallower. That's the beauty of CAIRS. You can put them shallow up, you don't have any melt. So as you can see, this is the CAIRS, this is the tunnel, it's 250 micron, it's safe sitting up there. And actually what you do is just do a femtosecond tunnel, and then you break the bridges with a mechanical dissector. You just insert it. Again, I use my jerky technique at 250 micron depth, so way above the initial implantation site. It goes smoothly, just like a ring segment, and from a diametrically opposite incision, you just pull it out. This is before, this is after. It's actually much better than what was the case with the previous rings. Another complication is neovessels. In these cases, you definitely have to remove the ring earlier because you don't want to jeopardize the possibility of a future corneal graft. Here, you guessed it, it's epithelial ingrowth. That's very nasty. You need to remove it as soon as possible. Otherwise, you will have a diffuse melt at that site. And finally, this is an aqueous complication. It's actually deposits in the channels. They're most of the time fatty deposits and proteinaceous. Sometimes they can be ugly and they can be cosmetically a problem. So if you remove them, they usually just resolve. This was a corneal ring complications. Thank you for listening.
Dr. Awwad, that was incredible.